Good morning, everyone, and welcome to CAHN's Health Hour. We're delighted you've been able to join us this morning. This morning, we're privileged to be joined by Dr. Ibi Erekosima, who is a consultant kidney physician and also an international facilitator for global kidney health. He is based at Salford Royal Hospital or the Northern Care Alliance. And this morning, he will be presenting on how we look after our kidneys, all this stuff around prevention, management of kidney disease, and any other questions you have for him. So at this point in time, pleasure is mine to hand over to Dr. Ibi to do his presentation, and then he will take questions at the end. Over to you, Doc.
Yeah, thank you very much for having me today. I'm going to just talk in a layman's language as much as I can on kidney disease. And it's a challenging alliance. I put the challenging alliance because it is a common cause of cardiovascular disease also. Like I've been introduced, my name is Ibi Erekosima. I work in Salford Royal. So I will start by introducing the topic, look at some background information on kidneys in health and interaction between the heart and the kidneys. And I'll also look at the major risk factors, which is hypertension and diabetes. And I'll just look at a brief case presentation to just give you some awareness of a kind of everyday life, how we present to the GP and all that, and management and prevention of CKD, and I'll conclude. So just an introduction, we all know that I'm sure most of you know that the kidneys are two bean-shaped organs. They're just the size of your fist. They are powerful chemical factories. They produce a lot of stuff. Some of them are good, some of them are not so good, some of them are very bad. And they also ensure that your body chemicals are in a balanced state, and they get rid of toxins and unwanted chemicals. I'm sure most of us know that when we go to wee and all that. And this is just a diagram of the kidneys. The kidneys actually are just under the diaphragm, under your rib cage, behind, at your back. The upper pole is at the tip of the rib cage. So that's where you find your kidneys. And the bladder is there, which I call a tank, which is a reservoir for the urine produced by the kidneys. So what does the kidneys do? As I've mentioned earlier, clean your blood, waste products, and extra water in your body. Make sure that you're balanced. They also help control blood pressure. I always say that the kidney is the seat of blood pressure control. And that's why when you have a kidney disease, the first thing that happens, your blood pressure begins to go up. I'm not saying that once you have high blood pressure means that you have a kidney disease, but high blood pressure is a common cause of kidney disease. So it's chicken and egg, which comes first. It keeps your bones healthy and strong. It makes red blood cells and keeps the balance of minerals in your blood. So you can see that the kidneys are very crucial in our day-to-day living and life. So I put this diagram. This is a simpler diagram to just remind us. It ensures that we don't have too much or little water in the body. It ensures that we have blood pressure control and get rid of waste. It helps with our bone health. And it also makes sure that our body is not too acidic or too alkaline. And it maintains an electrolyte imbalance and makes sure that our heart beats properly. And I've said this before at the beginning of the presentation, that the heart and the kidneys are intertwined. Once you have a kidney disease, it's likely that you have a heart disease because both of them share common risk factors. It also helps with blood cell formation. So that's what the kidney does. So it does quite a lot of things in our body. So what is the burden of kidney disease? Because for us to understand and and take this pretty seriously, we need to understand that it's a serious problem. So chronic kidney disease, CKD means chronic kidney disease. It's common and it's a serious problem. Worldwide, there are 50 million people suffer from the disease. And more than 1 million are treated with RRT. RRT means that renal replacement therapy, either dialysis or heart transplant, especially in the developed world. And WHO statistics show that it is currently the 12th major cause of death. So this shows that it's a serious problem. So what happens in the UK? What data do we have here? Around 3 million people in the UK have chronic kidney disease. And uncontrolled diabetes and high blood pressure are the biggest causes of CKD. So I'll talk about this more in detail in the course of the presentation. And right now, there are about 63,000 people treated with kidney failure, where kidney function is less than 15%. I will explain that further. There are 40 to 45,000 premature deaths in the UK every year due to chronic kidney disease. And so I put this in red because Black, Asian, and minority ethnic groups are 5 times more likely to develop CKD than other groups. So this is something serious for our cohort of people. So every day, 20 people in the UK will develop kidney failure. And this information is got from the Kidney Care UK. So if you go to their website, you get all this information. So chronic kidney disease and cardiovascular disease share common risk factors. And there are changeable factors and there are some that are not changeable. Smoking is a changeable factor. High cholesterol is a changeable factor. You can control that. Hypertension, obesity, diabetes, these are changeable factors. But the factors that you're not likely to change is age, sex is a bit debatable these days, genetics and ethnicity. So I put this slide to see that the heart disease and CKD have a common platform. So when your heart or kidneys cannot function normally, it can lead to cardiovascular disease. It is also important to know that having kidney disease can directly affect your chances of developing heart disease and vice versa. And kidney disease and heart disease are shared the same risk factors, like I said before, diabetes and high blood pressure. And so as your chronic kidney disease gets worse, your risk of having heart disease increases. And it suffices me to say that it is the cause of death in patients with chronic kidney disease, heart disease. So I put that information so that we'll be able to understand the context in which we're looking at this talk today. So if you look at this diagram, I just put that chronic kidney disease. So what are the risks? You have high blood pressure there, you have heart disease, which I've alluded to before. You have obesity, which is overweight and all that. I put diabetes is there, and then there's a family history. So if you have a family history of chronic kidney disease, you're likely to have disease. And chronic kidney disease is also a disease of those that are in middle age and elderly. So smoking also is a risk factor. Alcohol, I didn't put it here because it's an indirect risk factor. It can worsen high blood pressure and cause chronic kidney disease. So what are the common causes of chronic kidney disease? I don't want to bore you with the rest, but I want you to just look at these 2 major ones, which is diabetes and high blood pressure. So it is very important. It's a recurring statement. I probably say this several times. Diabetes and high blood pressure are the common causes of chronic kidney disease. There are other causes which are not as frequent. As you can see, the others are a very small percentage compared to diabetes and hypertension. So I just want to quickly talk about these stages of chronic kidney disease. There are 5 stages which we look at as kidney physicians. Now, I put on this side of this, on the right side of your screen is the percentage of kidney function. So stage 1 is when you have normal kidney function, and maybe there's a structure of maybe you have a protein in your urine, but your kidney function is normal. So we say that is stage 1. Stage 2 is when your kidneys are working at between 60 and 90%. Stage 3A and 3B is due to either is based on the quantity of protein in the urine. So it is either moderate, mild to moderate loss or moderate to severe loss, which is the stage 3B. So the percentages are there, 59 to 45% and 44 to 30%. So I put this on this side so that you'll be able to appreciate that rather than putting the technical aspects. So when you go and see if you have hypertension, have a kidney disease, when the doctor tells you that you have a GFR of 44, you know that it's about 40, your kidneys are working at 44%. So when you go to stage 5, it becomes kidney failure. That means that your kidneys are working less than 15%. So this slide here just emphasizes the link between chronic kidney disease, diabetes, and hypertension. It's such a very powerful alliance, and so I always say that it's almost like sitting on a time bomb when you have diabetes, hypertension, and you're likely to have chronic kidney disease. So CKD, cardiovascular disease, diabetes link, it's a disease, chronic kidney disease is a disease multiplier. So if you have cardiovascular disease, having chronic kidney disease kind of multiplies your heart disease. And if you look at it, the diabetes is there, chronic kidney disease is there. It's a multiplier. And so as your kidney gets worse, your kidney disease gets worse, your heart disease gets worse. And that's why I said earlier that cardiovascular disease is the commonest cause of death in chronic kidney disease. So the same illustration, which I'm just trying to emphasize the connection, hypertension, cardiovascular disease, and chronic kidney disease and diabetes. And so virtually most people who have disease also have chronic kidney disease. So we'll get to this. I'll talk more about diabetes and high blood pressure, but you can see diabetes, obesity, high blood pressure, and cholesterol. They are intertwined together, but we'll talk more about diabetes and high blood pressure. These are commonest causes of CKD, which I've mentioned before. So I just want to present this case of a gentleman. He's a 45-year-old black male of Caribbean family origin. He presents to his GP. The reason why I'm presenting this case is that a lot of times we don't know that we have this problem, especially when we're above 40. And so he presents to his GP with a sore ankle after going over it. I mean, he had a twist. And so his medical history, that he had no past medical history, and previous presentation have been related to coughs and colds. He smokes about 25 cigarettes a day and alcohol consumption around 20 units per week. And I wish he has done for 18 years. He works shifts, and so he's work shift both night and day, and says that he considers his diet to be unhealthy as a result, because he works shifts. So he visited the GP assessment. The GP noted that his ankle has sprained, but as part of the routine examination, his blood pressure was high at 160/100. So he was subjected to further cardiovascular risk assessment to discuss prognosis and healthcare options. So initially, the GP offered Mr. D lifestyle changes, advice, diet including salt and caffeine intake, exercise, his alcohol consumption, and to quit smoking. So because of his high blood pressure and all that, and he was referred for specialist assessment. The results of the specialist assessment are returned, and there are no secondary causes of high blood pressure. I'll talk about that in a bit. However, he was noted to have heart disease on his echocardiogram. His urine testing also had protein. So this all shows that he has target organ damage. The target organs that have been damaged are the heart and the kidneys. The kidneys because he now has protein in his urine, and heart disease because the echocardiogram shows that. So the reason for this case is that, most times we just walk around, we don't know that we have this problem. And if you didn't go to go and see the GP that he has an ankle sprain, you probably won't have known at all. Then the next thing we end up on dialysis. So this is something I put this case forward so that you'll be able to be aware that this is silent and it can affect you. So the GP had a management plan. Lifestyle advice was reinforced, diet including salt and caffeine intake as previously. And Mr. D's cholesterol level was marginally elevated. He was asked to reduce his fat intake and probably from his diet and all that. And the cholesterol was needed rechecking before considering tablets for his cholesterol. So he's now been put on medications for his blood pressure in addition to lifestyle modification to protect his heart and his kidney from further damage. So what happens is that it's right now, I think it's almost like halting the progression of his kidney disease and heart disease. So this is something I put because, a lot of times majority of us are not aware that we are carrying a cardiovascular disease or kidney disease. And once you get to that age, it will be as part of your check, you need to see your GP to check you at least once a year. So I'll now talk about high blood pressure. Well, I don't know whether you had talks on high blood pressure, but there's no identifiable etiology. And essential hypertension is the commonest. It accounts for 90% of hypertension. Typically onset is 40s to 50s. There's a genetic predisposition. There's a strong family history with racial pattern. And so it's a disease of Black people. And a lot of studies have been done in the African Americans. The common and very popular study known as Framingham study, where they studied African Americans for the last several decades with high blood pressure. So the contributing factors in high blood pressure is overweight, excess alcohol, excess salt intake, lack of exercise, and environmental stress. If you cast your mind back, if you're following the slides, these are also things that I've mentioned that is common to diabetes, also common, and hypertension is a common risk factor, as I mentioned before, for chronic kidney disease. So if you look at high blood pressure, the major organs it affects is there are four: brain, the kidneys, the heart, and the eyes. And the kidneys is something that is very common among our black population, and that's why I'm hammering it over and over. It's something that we need to be very much aware of. So the complications, if you look at the way the high blood pressure damages kidney, this is the way the kidney looks like compared to a healthy kidney. So this is the way an hypertensive kidney looks like. So once your kidneys are fried up by high blood pressure, you end up on dialysis or you have a kidney transplant. Otherwise, you won't survive. So diabetes, UK figures shows that diabetes is increasing. If you look at 1996, it was about 1.4 million people diagnosed. In 2019, there were about 3.8 million people. So this was got from the Diabetes UK. So the commonest among age group, the age group above 40 is type 2 diabetes. It's often associated with excess body weight. There is an associated high blood pressure, which I've mentioned before, with high cholesterol levels. It's usually treated without medication by lifestyle modification. Sometimes possibly come off diabetes medication if you improve your lifestyle, weight reduction, and diet. That type 1 diabetes is found mainly in children and young adults. And they will require insulin, but that's not quite common. If you look at the distribution, like I showed in the last slides, it shows that type 1 diabetes is not as common. So 90% of people with that have type 2 diabetes, which I've just mentioned, and then 80% will have type 1. So if you look at this data, this is from the UK Diabetes, Diabetes UK. If you look at it, the Black Caribbean population probably among the men has 10.5% prevalence compared to Black African. And then the Bangladeshis followed, but the Indians have, Indian men probably are the highest. But if you look at Black Caribbean women and the Pakistani ladies have the highest prevalence of diabetes. And so this also confirms the fact that why chronic kidney disease is several times over in our population. So this is what diabetes does to us. It damages our kidneys, it damages our eyes. It's a very big risk factor for strokes, 2 to 4-fold increase in cardiovascular mortality and all that. So you can see that it's a recurrent thing on the kidneys, as I mentioned before. And this is what cholesterol does to your blood vessels. And that's why we have strokes. So even in the kidneys, it causes clog up of the small blood vessels. And it disseminated cholesterol emboli and all that. So obesity, if you look at it, it causes kidney disease, it causes heart disease, it affects blood vessels, it causes stroke. So it's all the recurrent information that I'm just saying to just buttress the point that these things are very serious. And the more overweight you are, the likely that you have any of these problems like diabetes, hypertension, and chronic kidney disease. Overweight, this is a BMI of adults. And this is a grading of overweight and obesity. So the more overweight and obese you are, the likely that you have these health problems. So I'll just go through the symptoms of chronic kidney disease. Most of the time, there are no symptoms, but symptoms begin to develop when your kidneys go below 30%. In my previous slide, like I showed. So it's a silent killer. So one of the things is you begin to feel sick and tired, and these things are mainly occur when the kidneys are less than 20%. And then your ankle could swell and eyes could swell, bubbling of urine, persistent itching and dryness of your skin. And you'll be breathless because there's water retention everywhere. You have sleep difficulties and waking up at night and also passing urine at night. So those are the things that you will find with the symptoms. But like I said, symptoms do not happen until when your kidney function is less than 30%. So how do we treat it? We normally treat, 2 ways we treat it is to slow the progression of the kidney disease. And then once you go into established kidney failure, we will put you on dialysis. So dialysis is either peritoneal dialysis or hemodialysis. Peritoneal dialysis, in which you have dialysis to read the tummy. And then hemodialysis, you have it via through the blood, the clean blood, and it goes back to the machine. And then kidney transplant. So these are the ways that we treat, these are the ways that we manage chronic, end-stage chronic kidney disease. But I must say that if I go back to the previous slide, well, this is where I am very particular about slowing progression in the treatment. But in terms of management, I always, I'm a fan of prevention. Because it's better to prevent than to treat. So preventing CKD and cardiovascular disease, I always say that an ounce of prevention is worth a pound of cure. And this is something, this is an that most of you know. Diet and exercise to maintain a healthy weight. I can't overemphasize that. And then smoking cessation is so important. Diabetes needs to be controlled, and blood pressure. I will talk more about blood pressure control. There are a lot of myths around blood pressure control amongst our population of Black people. So control cholesterol, avoid excess over-the-counter pain medication, especially ibuprofen, diclofenac, and all these. I've seen several patients who have come to my clinic with kidney disease and damage because they were taking these medications without medical supervision. And then also some herbal preparations are also harmful. Excessive intake of them. Some people argue that some herbal preparations have some health benefits. I'm not disputing that, but one has to be careful because there are enough evidence that herbal preparations are associated with toxic kidney disease. And so regular checkup with your primary care physician, especially when you're above 40 years old. So how can you keep your kidneys healthy, which I've said before? Regular physical activity, at least 2.5 hours every week. It could be just brisk walk and aerobic exercises. Lose weight if you need to. Eat less fat. Keep your blood pressure, blood sugar. If you have high blood pressure, you need to be controlled. Blood sugars need to be controlled, diabetics. And then stop smoking. I didn't say is smoking cessation, not reducing smoking. Keep well hydrated and drink at least 2 to 3 liters every day. And then try as well to reduce your stress and distress yourself. So the thing is that how do we achieve this? The risk of developing complications can be reduced by following health style measures, which I've already mentioned. And so the only area that I will just talk about is low alcohol intake, which can affect your blood, which will be good for your blood pressure. So busting the myths in hypertension, this is an area that I've had some of our patients who come to see me, especially among our Black population. Hypertension is not a temporary illness that will resolve. So some people think that hypertension is a febrile illness, it's going to resolve. It's not going to. It's a lifelong illness in which you need lifelong therapy. The absence of headaches or dizziness or symptoms does not mean good hypertension control. You only know good hypertension control if you check your blood pressure. And the target usually is discussed with your GP. Usually the target is less than 130/80 for the generality of the population. There is no need to experiment with stopping treatment to see if symptoms reoccur. So that's the only time that, the only sign you see after stopping your treatment is that you probably have a stroke or a heart attack. So that is not something that is advisable. So do not stop medication because you don't have because of lack of symptoms. So do not wait for symptoms before you take your medications. So you take your medication regardless. So long-term medication is not harmful and does not have any risk of tolerance, although people will have side effects and your medications can be changed. And dependence on the drug build up to harmful levels is not something that we encounter, although some of the medications, if you have other underlying medical problems, could interact, and that will be sorted by your physician. Alternative medicines are not more effective, but may result in complications. I say this. I've seen patients who have had their kidneys wiped off by taking alternative medicines by way of herbal preparations. So that is something that we should be very careful, especially with regards to keeping your kidneys healthy. So be aware, high blood pressure is a silent killer because many people suffer it, like I've demonstrated in the previous slides. You could just fire up your kidneys, and 1 in 3 have high blood pressure and don't know. So you should take proactive measures. So lifestyle intervention, I always say know your numbers. I've mentioned this time and time again: healthy eating, smoking cessation, physical activity, alcohol consumption, and weight management. So these are things that we need to bear in mind. And then so one test when once you're above 40, blood tests, kidney, cholesterol, and glucose, echocardiogram for your heart. But these are the things I want to mention: the blood test and the urine test. These are simple tests that can identify whether you have underlying kidney problem, especially if you have high blood pressure or diabetes. So these things are quite important. They are basic, which you can arrange with your primary care physician. So the point I'm trying to make is that there's no myth around the kidney disease. It's a simple disease, and simple things can be used to prevent it. So it's something that we need to bear in mind. So it's not something that is beyond. It's beyond when we don't take action on time, and then we now end up on dialysis or will require kidney transplant. So finally, this is just know your kidney and heart health, food, exercise, your habits, compliance up to treatment, healthcare, environment, and genes. I mean, genes you can't change, but there are a lot of modifiable things here that you can change for your kidney health. So if you can see that most of the things I've said here, they're not really rocket science. They are things that are pretty modifiable. So the key messages are that CKD, CVD, CKD is chronic kidney disease and cardiovascular disease, diabetes and hypertension are all very common. I've demonstrated that in the slides from the data from Diabetes UK, Kidney Care UK. And lifestyle, poor diet, lack of exercise, tobacco abuse, excessive alcohol are significant risk factors. So, and these are modifiable. And I've always believed that prevention is the key. Like I mentioned before, it's worth more than a pound of cure. So health check with your primary care physician is important to screen for and manage these diseases. So the key thing is that kidney disease is manageable if you are proactive, not reactive. And also the case discussion that I just put up is a gentleman who did not know that he had both kidney disease and heart disease. So that's something that you must bear in mind in regards to kidney disease prevention. Thank you. If you have any questions.
Thank you very much, Dr. Ibi. We've got loads of private questions, and I'm sure, my colleagues on the line will also have different questions, for you.
Yeah.
So as you stated earlier, there's, from research, it's that Black people are 5 times more likely to get kidney disease. Is this intergenerational, or in other words, does it have epigenetic factors?
I mean, it's a combination of factors. Now, the reason why
if you stop the screen share, then people can really see you.
Okay, right. Should I remove stop the share?
Yeah. If you stop the share, yeah, fantastic.
Okay. Right. So the thing is that there are many factors. Like if you look at some of the diagrams I've shown, it's not just one single thing. I mean, Blacks are genetically have diabetes and high blood pressure. So the fact is that with the combination, that's why I call it a challenging alliance. The Black people and the Asian subcontinent have a greater increase in kidney disease. So that is, if I may ask you, if I answer your question, that is part of it. So there is a significant influence of our genetic makeup, in having kidney disease. And if I may just mention, another thing that we should also understand is that the African kidney retains salt compared to the Caucasian kidney because of our environment and all that. And that's why our blood pressure management is volume dependent compared to Caucasian. So some of the medications might not be very effective in Blacks.
Doc, you said volume dependent, but could you break that down for the ladies?
Okay, so sorry, I'm just trying to be technical now. What I'm trying to say is that if your kidneys retain a lot of salt, which means that it attracts water, so your blood volume will increase, and that could increase your blood pressure. That's what I mean.
Okay, thanks, Doc. So why is it, maybe you might have touched on it, but it's a question that's come through. Why are Black people more likely to get CVD-related conditions at younger age profiles compared to other population groups?
Okay, so CVD is cardiovascular disease. So now the reason why Africans are getting more of that is that because Africans, if you look at the epidemiology, high blood pressure is young. We develop high blood pressure at a younger age. Most people, if you take a sample of Afro-Caribbean, African people, or African American from the Framingham study, they've done a big observational study in America where they followed up people for decades and decades. They found out that most people begin to develop high blood pressure in their 30s. And so some of them don't know, so the likelihood that they will develop cardiovascular disease early. Does that answer the question?
Okay, Doc. I'm going to ask one and I'll bring in Dominique, but I'll ask this question. It's a private one that has come. Please, does having a big tummy affect one's health, considering the fact that it increases BMI? So this person is asking about, a big tummy or big stomach or pot belly.
Yeah. Now, basically, if you have abdominal gaps, that is, we talk, if people who are overweight, there are different types of fat distribution. If you have a fat distribution that is around your trunk mainly, there's been an association between fat distribution around the trunk to cardiovascular death. You're likely to have cardiovascular disease if your distribution of fat is around your tummy. And so one of the things that this is where it is very important to begin to recognize these things early, because once they're established, it becomes difficult to get that down, which means that you have to do a lot of exercise and all that to get your at least the fat around your trunk down. So there's enough evidence in the literature in science that people who have their fat distribution is more at the trunk are likely to have more cardiovascular complications from cardiovascular diseases.
Okay, Doc. There were a few people who joined late, and one is said, he or she wants to know the symptoms of CVD and hypertension, so that we can bring the other questions as well. So this person wants to know some of the symptoms. Okay.
The interesting thing is that high blood pressure does not have symptoms in majority of people. Like I used that gentleman that I put a case presentation. I put that purposely to just highlight the fact that you don't have symptoms. He went to the GP for something totally different. He had a sprain in his ankle, and he went there and they checked his blood pressure, and his blood pressure was high. And so they now referred him for specialist assessment. So majority of people don't have symptoms, but the symptoms those that have symptoms are mainly headaches and dizziness. And so that takes them to the doctor, and then they check the blood pressure, and the blood pressures are high. And now when you say CVD means cardiovascular disease. If you have a heart disease, you got chest pain, you get breathlessness, and your ankles might swell. So those are when you have an established heart disease from the high blood pressure.
Okay, thanks, Doc. I'll bring in Dominique, and then later we'll go to Bumi. So Dominique, you can unmute yourself and ask your question.
Thanks, Charles. Thank you for sharing your knowledge, Dr. Ibi. I just wanted to ask about some of the symptoms kind of reflect some of the symptoms that a pregnant woman could have. And sometimes pregnant women as well do have diabetes or diabetes during pregnancy, which is literally just during the pregnancy. How are those related, and should a woman pregnant with all these symptoms be worried that she also could be having kidney disease, knowing that the symptoms are kind of similar? And as you said, the symptom doesn't sometimes show until it gets to a later stage. So what would you tell a pregnant woman with these symptoms, and how can she mitigate, or what can she do to take it further?
Okay, now let me ask. I think the question is in two parts now. First of all, there's what we call hypertension predating pregnancy and pregnancy causing hypertension. There are two aspects to it. Now, for somebody who has been hypertensive and they don't know before they got pregnant, you know, they are early in the pregnancy, their blood pressure goes up and their legs begin to swell and all that. So in the first trimester, in the first 3 months, they become hypertensive, which is not very common in pregnancy. Most pregnancy-induced hypertension occurs in the last 3 months of pregnancy, or from the mid-trimester downwards. So if somebody in the first trimester comes to a clinic and they have high blood pressure, then there should be a suspicion that this person might have high blood pressure that has not been recognized before they got pregnant. So now, the other aspects of it are if they now become hypertensive late in pregnancy, and that is because of the pregnancy that's causing the high blood pressure. And majority of people, after the pregnancy, their blood pressure comes back to normal. A small number of people might continue to have high blood pressure later in life. I mean, it could just prolong, and they will continue with medications for quite some time. Now, there are some people who perhaps have kidney disease before they became pregnant. They didn't know that. They might have high blood pressure before the pregnancy. They didn't know that. And so pregnancy might just exacerbate everything. And so I want to also say that if you got kidney disease that is not recognized before you got pregnant, the kidney disease will get worse with pregnancy. And so that's why I'm saying that for those ladies that have late, who begin to have their children late in, say, above 30 up to 35, it's something that you need to be aware of and have to liaise with your GP. I don't know whether this has answered your question.
Yeah, thank you. Thanks, Dr. Ibi.
Okay, thanks, Dominic. Bumi, can you unmute yourself and ask your question? Then we'll go to some of the private questions.
Yes, thank you very much, Dr. Ibi. Thank you so much. Just two, I think, simple questions. One is, you did say chances of, if you have a kidney disease, of developing a heart disease, like more like it goes together, that's
yes.
very high. I was just wondering if, is also like the other way around, like if you have a heart
yes.
disease, that you are more likely to develop a kidney disease. Would that be right? Then
yes.
the second, not really question, and question kind of is like, as Africans, do you think that our diet makes us, the risk factor higher? Is that one of those things that you could say predisposes us to kidney disease? I don't know. Thank you, Doctor. Yeah. Okay.
That's a very interesting question. Like I said, heart disease and kidney disease are like an unwholesome alliance, because if you have heart disease, you're likely that you have renal artery, renal vascular disease, or, it will affect your heart. Or if you have heart failure, because there's blood supply to your heart, to your kidneys, and not if it will affect your kidneys, or the other way around, if you have kidney disease, you're likely to have, because of the toxins and a few things, you're likely to have that disease earlier, or because of the common risk factors of diabetes, hypertension, both affect both the heart and the kidneys. And so they kind of affect both organs most of the time. Now, in terms of diet, African diet, two things I want to say is we have good food as Africans. We have good food, but the fact is that I don't know, traditionally we deep fry a lot. And that's one. Number two is that we eat big portions. Really like it's a common African thing. We like big portions. If you go to an African restaurant, if you look at the portion, they give you big portions. So we're used to eating big portions. If you eat big carbohydrates, of course, it's going to you're going to have most of these are going to be deposited in your body and all that. But having said that, I say we have good food. We have vegetables. We have all these other things. But I think it's just the way we eat our food that is a problem. I hope that answered the question.
Yeah, thank you.
Okay.
Okay, Doc, there's another private one here. What can be done to get high cholesterol down when I exercise, eat healthily, do not drink or smoke, and not overweight?
Okay, now, most people that have high cholesterol is due to modifiable things, either due to their diet or due to overweight or diabetes. Now, there's another group of people who have cholesterol, although they don't have any other of these risk factors, in which case they may have a family history of high cholesterol. So there's another group of people that though they don't have any of these risk factors, they might have high levels of cholesterol. I've seen such patients in my practice. And so what we do, we investigate those further to know whether they have some of the subsets of cholesterol and all that, and then do some family screening and all that.
Thanks, Doc. So
just to add that those kind of patients will require long-term medication to control their cholesterol.
Okay, Doc. So there's a follow-on question from this person. Is there any evidence that becoming a vegetarian could help combat high cholesterol level?
Yes, I mean, of course, if you're eating vegetable protein, but if you look at vegetables and the kind of things that are contained, they don't contain the bad cholesterol at all. Most of the vegetables have good cholesterol and all that. And so it is, in terms of food, I think it is something that is advisable. I've not seen any data concerning just vegetarians where they've taken vegetarians and then monitor them. Those data might be there, but I have not come across them. But my thinking scientifically is that if you're eating just vegetarian diet, your likelihood of having high cholesterol will be low.
Thanks, Doc. So another question, can we really prevent hypertension given that it's possible, as a result of, hereditary factors? Can we really prevent hypertension?
I mean, it is difficult to say you can prevent hypertension, but you can prevent the complications. So because hypertension, let me just give an example. It's a combination of factors. So you might have a genetic predisposition to having high blood pressure, but your environmental factors can facilitate you having it early. So rather than having hypertension early in your age, you could have it much later in your age because you have a genetic predisposition. Because age itself is a risk factor for high blood pressure, especially if you're genetically predisposed to it. So there are so many other factors. Now, having said that, that is the onset of high blood pressure, But in terms of the complications, you can prevent that if you take your medications and change your lifestyle. So there are two aspects to the answer.
Okay, Doc. So if you are placed on medication for high blood pressure, is that for life, or just by making lifestyle changes, including stopping smoking, that, will that ever get you to come off the medication?
I mean, I always say that once your medications for high blood pressure is a lifelong thing. Now, the reason why we say that lifestyle modification is going to help is that as in the course of your high blood pressure, you will see that rather than having one tablet to control your blood pressure, you require 2 or 3. But with lifestyle modification, you might just have one tablet controlling your blood pressure. In this day and age, there are very few patients that just have one tablet that is controlling their blood pressure. But when people really vigorously pursue lifestyle modifications, there is the fact that they will require less medications to control their blood pressure. But you will have medications for the rest of your life. Now, there are some patients who, when they lose weight and they change their diet significantly, their blood pressure drops to a point that their medication, the medication begins to cause side effects for them. And so what we do in that situation is to reduce the medication to the barest minimum. And if you are still having symptoms from the side effects of the medication, because your blood pressure is getting too low, then we stop it. That is only in that situation we stop medication.
Thanks, Doc. Bumi, have you got another question?
Yes, I have another question. Thank you, Doctor. I know a gentleman who is on I think antidepressant, citalopram and all that, and suddenly he begins to add weight. I'm not saying that either, but I just want clarification. Do you think some medication have, predisposes us more to kidney or heart disease and that, for someone who has not been, who does not have that diagnosis before?
Okay. Now, what if the person is taking citalopram, this person is taking it for depression, is that or anxiety? Is that what it is?
I think it's anxiety, yeah.
Anxiety, okay. And there has been an association between anxiety and depression and weight gain. So anxiety and depression itself is people gain weight. Some people just they call it comfort eating. They just eat and get comfort from the anxiety and depression. And so that could be the reason why he's adding weight, not specifically the citalopram. And so if it's the other way around, which is that he's eating so much to gain weight and all that, which means that you're at risk of having type 2 diabetes or high blood pressure in the future. So it's not very common for antidepressants on its own to cause weight gain.
Weight gain, okay.
Yes, it's not very common, but there are some antipsychotic tablets, not antidepressant, antipsychotic tablets that can cause weight gain. The ones that we use for schizophrenia and all that.
So does that have effect on the kidney? Does it have any effect on the kidney? If
you're eating uncontrollably and comfort eating because you're anxious and depressed, of course you're going to gain weight. Of course your blood pressure is going to go up. You might begin to have type 2 diabetes, and that can affect your kidneys. It's indirectly, it's not direct effect.
Okay. Thank you.
All right.
Thanks for that, Doc. I mean, considering the issues you alluded to earlier on about Black people and our kidneys retaining salt and all that, what screening would you recommend for Black people, given that we're more likely to get some of these CVD related conditions, and also considering that the general health checks is usually promoted to people 40 and above? What other would you recommend for the Caribbean and African community?
I mean, basically, what I always say is that, I'll just split it into a few sections. I mean, let's look at diet now. Like I said, I mean, where I come from, we eat big meals, and so you need to cut your food portions, cut down your food portions, and eat more vegetables and fruits. And then the salt intake is something that we need to also look at. I mean, worldwide, it's recommended that you don't need more than 6 grams of salt per day, which is a teaspoon. I know people will be wondering, why should I have it just a teaspoon per day? But that is what is recommended. So these things have to do with discipline. You need to be sure that you take this, you adhere to these measures, because sometimes it can be difficult at the beginning, but once your taste buds are used to it, you will be able to cope. So that is about diet. We must reduce our portions, and we need to make we have healthy foods of local foods and vegetables are healthy. So there are some that are healthy, but it's the way we go prepare it and all that, and we will preparation. We need to use more healthy oils and all that to cook and all this, knowing fully well that we are more predisposed. And then in terms of exercise, I think most of us don't take that as part of our lifestyle, exercising. When I say exercise, it's not, I tell my patients that you don't need to go and register in the gym if you can afford it. All you need to do, if you're around a place where you can take a walk for about 40 minutes or up to about an hour, just walking about 2 miles around your neighborhood, you'll see that if you do that 3 times a week, you'll be fine. So you don't need to go to the gym to go and register, because that is expensive for some people. And so we need to recognize that. So I think, and then smoking cessation, not cutting down. You need to stop smoking if you're smoking. And then alcohol, nobody says that you shouldn't take alcohol at all, but you should limit it to 14 units. And that is the nationally advised number of units. And if you go to the website, it's very clear there. Even they demonstrated the various meals that you can take, both in wine, alcohol percentage, and the beers and all that. Occasionally, in social gatherings, you can have a slight overtake, but it should not be a routine thing. So it's just living sensibly, and that's why I put it.
So, Doc, you talked about exercise. I mean, considering some of us, we do 2-3 jobs, and some of it are manual. Would you still recommend we do daily exercise?
Well, that's the problem. People think that because I'm hoovering the house, that's an exercise. No, that's not. You're hoovering the house. It doesn't mean that you should not. I mean, there are these aerobic exercises. You breathe in, fresh air in your lungs and things like that. Now, you see, you have 3 jobs. So those 3 jobs might be jobs that you're just sitting down like I'm doing now. For those periods. So you might just go from one sitting job to another sitting job to another sitting job, and majority of us will not want to take the stairs. We want to provide the lift. So that's another thing. If these days we have people are tech savvy. Yeah, they have smart watches where you can count your steps. If you can do up to, I mean, if the steps can be calculated, can be converted to miles. You can get a smartwatch, or there are a lot of cheap smartwatches around. You can count your steps and convert it to miles and see how this is helping you and all that. I think that I don't believe in obsession with these things, but it has to be part of your lifestyle. Then it becomes fun.
Thanks, Doc, for clarifying. So whether, I have 2-3 cleaning jobs, whether I'm an agency, healthcare assistant working on the board and stuff, it's still important to have dedicated time for exercise.
Yeah. Yes.
Okay.
Yes.
Yeah.
So just to mention again that those that, for example, the healthcare worker, of course, maybe she's working in a nursing home, they're carrying patients up and down, does not mean that it's a stressful job. So you need those walks that we take can also distress you.
Thanks, Doc. So on Tuesdays, we have our Healthy Heart session, which focuses on physical activity and nutrition. So please make sure you join every Tuesday, 6:30 till 7:30. So I have another private question, and then I'm going to go over to Dominique.
So sorry, somebody just said that, Dr. Ibi, please, do you think that they're talking about nurses and healthcare workers which I've just explained,
so just by walking on the ward, it doesn't mean you exercising.
Yes, it doesn't mean. I mean, I keep running up and down, but I still want to come and do some walk of 40, 50 an hour walk around. Like I said, you don't need to if you can't afford to go to the gym, all you need to do is to stop entering your car. If within your locality there is a shop, you can walk to the shop and back. Some of those changes can help you.
Thanks, Doc. That's a big issue, because when we, in this day and age of WhatsApp photos and stuff like that, we want, our families to see our nice cars and stuff. But, it's good you've mentioned the walking. So a couple of questions more. So one is, you know, if at some point in time you can touch on the effect of medication and how that, you know, the side effects associated with medication, how that adversely impacts on, you know, the organs. And then there's another one, you know, for you to explain more about heart failure and kidney disease and how that could be managed.
Okay. Now, talking about medications, I mean, one of the things that any good physician will do when they start on medications for blood pressure is to tell you the side effects. I mean, some of them are you feel dizzy, sometimes you might have dry mouth and all that. And for males, you could have one of the commonest reasons why males abandon their blood pressure tablets is because of erectile dysfunction. That is what we've seen, you know, because it affects their quality of life. But those are conversations that you need to hold with your doctor. That if you're put on this medication and you think that it's affecting your quality of life, you need to address that with your doctor because these medications are lifelong medications. So that should not be a reason to abandon treatment because there are newer drugs that can be friendly that can help you bring down your blood pressure, but give you minimal side effects. I mean, there's no medication, there's no chemical that you take that does not have some bit of side effect. If you look at any medication, just look at the leaflet, you'll see that it has one or two things, but majority of people don't. I mean, I would say that more than 95% of people don't have these side effects, and only very small percentage. Now, the common side effects, like I mentioned, is you feel dizzy when you get from sitting to standing position, in which case it means that either your blood pressure is when you get up, it drops. So in which case you might need to see your doctor to review your medications and all that. You could have dry mouth and all that. And there are some medications that can make you wee more than usual, like the thiazide ones. You know, they can make it. So those things are things that will be explained to you by the doctor. But if it is causing problem for you in terms of your quality of life, then you need to discuss with your doctor. Now, coming to cardiovascular disease and kidney disease. Cardiovascular disease, like I said, and kidney disease have common risk factors. They have diabetes, hypertension, high cholesterol, all these other risk factors affect both organs. Now, when you have heart failure, I mean, you have a heart disease, there's a difference between heart disease and heart failure. You could have heart disease without heart failure. Heart failure means that your heart the pumping activity of your heart is not efficient anymore. So you could have a heart disease where your muscles, the heart muscles are just big, but they're still pumping all right. So, but if you have heart failure where your heart is not pumping effectively, it's likely that your kidneys will be one of the organs that will be affected. And so because the blood supply to the kidney is not enough, and so the kidney function might go down and all that. And also sometimes the treatment that they use for heart failure can affect the kidneys. So that's about that side. And now the kidneys itself, you know, in the course of the kidney disease, people develop heart disease because of the common risk factors. And so, and then as the kidneys develop inability to get rid of all the toxins, it begins to affect the heart. And so what kills people in kidney disease or kidney failure, those that have gone to the stage of dialysis and maybe the late stages of the advanced stages of kidney disease, is actually heart disease that kills them. You know, so those are the things. So in terms of prevention, the action you take for kidneys will also affect the heart. So it will improve the heart and all that, vice versa. So have I answered the question?
Yeah, thanks for that, Doc. Dominique, I know we've run over a bit, but you know, give us a bit of time because it's very difficult to come by, Dr. Ibi.
Thank you.
No problem.
Charles. Thanks, Dr. Ibi. I just have a quick question in terms of, you mentioned that we should have regular checkup when you get to the age of 40. I'm not 40 yet, but the question I'm asking is what would you advise? Because sometimes when you go to your GP, it's literally a quick 15 minutes, 10 minutes to be able to have a consultation. and you go in without having any symptoms, decide I need to have a health check. Sometimes it's like, I don't think you do. I mean, it's like questions will be going through, which sometimes none of those symptoms will be there. So what would you advise someone that really want to go through those checks to make sure that, you know, to just have that reassurance when we know that sometimes if there are no symptoms, doctors do not want to take us seriously, knowing that we also have that background that we've coming from the Black minority. Sometimes they do not have that, they do not take that into perspective when they want to have a consultation with patients.
No, that's a very important question. It's not just you. Most people are struggling with having an appointment with GP, especially the ethnic minorities. Now, there's something I want to advise here is that most times the GPs do not lay emphasis on those that are less than 40. Unfortunately, that's the government, because the NHS is free. So government is trying to limit resources to this population. But one thing I always advise people, especially the Black population, is that it doesn't cost much to buy blood pressure equipment. You can go to Boots and buy one. It's just about £25. You can forego a few meals, and then if you're going out and then buy that. So if you keep a record of your blood pressures and you're not happy, you can phone your GP. So that's one way that you can tell your GP that, look, I'm not right. I need sorting. So it's like you are proactive, you're not reactive. And so that's probably my advice, especially for those that are getting to 40, because if you're 40 and above, most times GPs will want to do stuff for you. Have I answered your question, Dominic?
Yes, you have. Thank you. I think I'll probably
So if you just buy one and just keep a record of your blood pressure. If it's fine, it's fine. You know.
So Doc, you know, what range is fine?
I mean, when I say range, okay, that's a very good question. I didn't dwell on that. If your blood pressure is consistently above 150/90, then you need the doctor to look at you. If it is for young people, I mean, if it's for young people, the bracket before was around 140, but in real life, sometimes your blood pressure is about, but it's consistently 150. But if you take it and it is consistently above 140, getting to 150, and then it is above 90, between 80 and 90, it's always like that consistently. When I say consistent, it's not one time you take it, you just run to the GP. They'll throw you out of the GP, just surgery. You know, so we say that if it is consistently above 140/80, you should, yeah.
Thanks for clarifying that, Doc. So it means we can all invest in a blood pressure monitor, although sometimes the readings from the home kits might be slightly different from what
but that just gives you a crude assessment. So if you go to the GP, they might recheck it, check your weight and all that. And so I always say that if you see that your blood pressure is gone and you're gaining weight, just reduce your weight by 2-3 kilograms. That blood pressure will drop.
Right. Okay. Thanks, Doc. Yeah. Another one. It looks like this question doesn't go our way, but can you clarify when one can come off medication for high blood pressure? I know you've touched on it.
Say that again.
I think someone wants further clarification. About coming off high blood pressure medication.
Okay. All right. So the point I made was that, as a rule of the thumb, we do not discontinue blood pressure tablets. That's a rule of thumb. That's the teaching we give to doctors, that you do not stop medications because it's a lifelong medication. Now, the only times that we stop medication, if somebody is lost weight, he's doing some lifestyle modification, and the blood pressure tablet is taking only one, and it is giving you side effects. In that the side effect is giving you that your blood pressure is always crashing. In which case, because of lifestyle modification, you don't need blood pressure tablets again, but it is very rare. So it's only in that situation that we normally will say that, okay, discontinue this. But 9 out of 10 times it's for lifelong. Have I answered it?
Yeah, thanks, Doc. Any final question for Dr. Ibi? Yes, Bumi.
Sorry, it's me again. Yeah, just in regards to this when to stop high blood pressure medication, how I think there's been a situation really that if that blood pressure is consistently low, say for 1 year, lower, not like too low, but where it should be, which I think maybe like 110, 70 and all that. And this has gone on for like a year, a long period, maybe over 6 months. Is there no review that's, because I think I've seen that happen before, like a review that, no, you don't need to continue this medication because this person is now changed the lifestyle, exercising regularly, changing diets and all that. Is that a possibility? Because I think I've seen that happen, or someone has said that happened before. Yeah.
No, I think that's what I said. I said what I said was that if somebody has low blood pressure, you have to have symptoms from that low blood pressure. You're having that low blood pressure because you're on medications, If you stop the medication, your blood pressure is going to go up.
Sorry, doctor. For someone that had high blood pressure and was on high blood pressure medication for a while, and also changed lifestyle, diet, and other things, and continuous review shows that this blood pressure has dropped and it has remained consistent.
The point I'm trying to make is that the blood pressure is down despite, forget the lifestyle modification. We do not stop blood pressure because your blood pressure is within the normal limit. We do not stop blood pressure medications. I've never seen that done in science. The blood pressure is down because the person is taking blood pressure tablets. Now, I do not know whether the person is taking more than one type of blood pressure tablet or 2 types of blood pressure tablets, because the majority of people who are hypertensive are on 2 types of blood pressure medications. Majority of people. Now, that kind of person, they can reduce the medications to just 1 and give the patient the lowest dose. It is very difficult. It is very rare for us to discontinue, except it is causing side effects. When they are on just 1 agent and it's causing side effects and their blood pressures have been okay.
Okay, thank you, doctor. Yeah, thank you.
No problem.
Okay, so thanks everyone for joining us. Doc, one more question. Once again, as CAHN, we look to influence policy and practice. Is there anything we can do as a community to lobby and campaign for a change to the benchmarking, which, means that GPs will prioritize people 40 years and above, knowing that some of these conditions do affect our community a lot earlier?
Now, that since after the COVID, COVID was an eye-opener to me too, in terms of the risks that our people face. Because when we looked at the data, most of the people that died who are from ethnic minority had underlying cardiovascular disease. And so what does that tell us as physicians and also policymakers, which meant that should this group of people be treated differently? So, for example, the government will need to bring out guidelines that if you're Black and you're this, you're that, you will need to get a check. Maybe if you're 40, you need to get a check as early as possible. Because COVID was able to highlight that people have very cardiovascular disease that put them at risk of dying. So that is something that we can hold on to, because that data was quite strong, and then with the fact that, we are more likely to die of kidney disease than any other than the white population.
Thanks, Doc. I think we'll pick that up. There's a question. I'm on BP medication, which is controlled, but I have a constant drumming, which my GP has failed to diagnose. How best can I explain this to my GP?
Yes, if you say a constant drumming, is it tinnitus, or is it that the person is not
Charity,
hearing?
do you want to ask your question? Unmute yourself and ask.
Oh, hi. Thank you, doctor. Can you hear me?
Yeah, I can hear you, yes.
Thank you. It is, it's like drumming in my ears and my head. So when I explain to my GP, she gives me like this look like drum. What do you mean drums? But it's there.
Okay, because the way we describe abnormal sounds that you hear from your ears is the first thing that I ask: is it tinnitus? Is it the ringing sensation? Something is ringing there, because if it's an abnormal sound that you're hearing, it sounds more like tinnitus. So if in that case, it's likely that it's not related to your blood pressure tablet. They need to look into your ears to know whether there's something there that is causing the problem.
Sorry, it's not, okay, it starts like from my chest. I can feel it's from my heart. Then the noise comes out through my ears. Sorry.
No. This description is very complex. So it's not. That's why your GP is not been able to help you, because it's very unusual for sounds to come from the chest and begin to go to the ear. I don't know the kind of job you do. Some of these things can be anxiety related. I don't know what kind of job you do. What kind of job do you do, ma'am?
I'm a support work, doctor.
So that's a stressful job, and so basically it's possibly related to some of these things, and because I cannot explain why the sound goes from your chest and begin to go into your ears and all that. It's very difficult. That's why probably your GP has not been able to help you.
Oh, thank
difficult
you.
Doc, are there any tests you would recommend for her to ask the GP to?
I mean, one of the things that she can do is that, is it the medication that is causing the problem, or it is a problem on its own? Because high blood pressure on its own does not cause ringing in the ears. So the other thing that if you're having those kind of ringing in the ears and they look into your ear, it's not working, they do a scan of your brain to know whether there's anything that's causing the ringing in that part of in your ears. But the way she's describing it is like it goes from the chest and things, and it goes to the ears. Now, the other thing that I will say is that I don't know whether she has gone through the usual MOT for people that have long-standing high blood pressure. One, they need to do a ECG, echo, and sometimes you could do a 24-hour ambulatory blood pressure for a start, and then check your urine and all that. I don't know whether they've done that for you before. Have they?
Charity?
Yes, doctor. I have done all that, and the doctor has also, my GP has changed medication, but I don't know. It's still there. It is still there.
It's still there. So I think basically it's likely to be. I don't know. I've not examined you before, so it's difficult to say.
Oh, thank you, doctor.
So Charity, if you want to get in touch privately, then drop us an email, info@cahn.org.uk, and then we can have a chat, because one of the things we seek to do as CAHN is to help people from our community articulate exactly what they're going through, so that but also we're grateful for Dr. Ibi and the other colleagues, and they make themselves available to have private consultation, and that's one of the things we're really grateful to you, Doc, and your other colleagues that come on this call. So yesterday, for example, I had to refer someone. We had a GP. She's been ringing 111, having nosebleeds, and not been able to speak to someone, and we had one of our Nigerian GPs who was available, talk her through what she should be doing and stuff like that. Right.
That's no problem. I mean, Charity, she's in a stressful job, so you could just unpack what is going on in that job and things like that. Because if the GP has changed medications and she still feels like that, so we need to look at a lot of other issues and take some really good detailed history. Yeah.
Thanks.
I don't think that this is a forum for that. But some of the private questions she might not be able to, she'll be embarrassed to answer.
Yeah. And also one of the things that our volunteer Black nurses who used to, they used to accompany Dr. Ibi and other colleagues, so we went to a church in Middleton, Dr. Ibi gave a talk. We had Black nurses who did health checks. One of the things they've been talking about and they're really passionate and they want to support is an advocacy service where you'd have, a Black person with that health literacy, a doctor or a nurse, predominantly accompanying people to appointments. So, we can look into that. But Charity, by all means, get in touch. And anyone who has a question that wasn't able to ask, drop us a line, info@cahn.org.uk, or contact our helpline, and we will arrange for a private conversation. So thanks again, Dr. Ibi. We know you've been very busy, during the COVID times. You've highlighted, the risk factors, and, there are various pieces of work we're hoping to continue to do with yourself. And next week, as we celebrate Organ Donation Awareness Week, we're hoping to have a transplant surgeon and some specialist nurses, and that neatly builds on what you do. And, we're really grateful for your time. So any final words from yourself?
I mean, it's been a very delightful time. I've been very, I would say, privileged to be part of this and speak to our people, because we need to support our people, you see. So that people, because one of the things I've found out in the NHS is that people are not aware of what should happen to them, and they don't know how to navigate some of their clinical problems. So I think this is a very good forum. We'll be able to support. I'm a kidney physician in the Greater Manchester. We look after the network. So people who are struggling, even if they are struggling with certain things, if people who have kidney disease, who are established, who are seeing doctors and they are struggling, and they can't get answers, we're here to have them.
Thanks a lot, Doc. We're really grateful. So please, if you're interested in volunteering with CAHN, joining the advocacy service, you have a bit of health literacy and you want to support what we do, by all means, get in touch, because Dr. Ibi is right. From the screening that, our volunteer nurses did, of 600 people screened, we had to refer about 40% plus, or nearly 50%, to their GPs for further checks. So since Dr. Ibi and others are around, please let's make sure we use the, influential people that, God has given us. Dr. Ibi, before you go, kidney transplant and organ, it's a massive thing. Do you want to say a few words, about that, and also encourage our people to come forward, because you see patients who have been on the waiting list for so long.
I mean, there are two. In fact, in my several years of kidney medicine in the UK, I've seen just very few Blacks being transplanted. I've been in an advocacy group in London before. I think the problem is that there are a lot of myths about our own population too, about kidney transplantation. Our people don't have life-related donors, and that's one of the things that
I'm doing kind of three.
The life-related donors. Relatives don't want to give their kidneys to their relatives. I don't know whether it's out of their traditional beliefs or religious. I mean, I don't know why their belief system is, but people don't put themselves forward to be potential life donors. That's number one. Number two is that there is definitely not many Blacks are transplanted compared to the general population. And that the reason I don't really know, but there is a national matching system. I don't know whether that is from there, but our people too should show interest in being part of being either altruistic donors or, be part of the kidney donation programs, put themselves forward as life-related donors and all that. So that's one thing that we need a lot of campaign in that area, because there's a lot of religious beliefs, just like the Asian population. I have a lot of them in my patch in Rochdale and Oldham. That's been a problem. We've done a bit of awareness campaign in Rochdale, but we're still working on that.
Thanks a lot, Doc. So since we are aware of some of the kidney disease our people have, I think it's the more reason we need to come forward and sign up to the organ donation register. And Doc, finally, I know we've gone over time. Why don't people like, signing up to the register or giving organs when, their relatives pass on, or when people themselves pass on?
I think in our society, I mean, where we come from in Africa, I think it's a cultural thing. People have a lot of myths around it. I always say busting a myth. I mean, one of the things that I was part of a family that a daughter donated to our mother. I mean, that was the best I've seen. A Nigerian daughter donating kidney to her mom. And there was a lot of questions that were being asked when I was trying to get involved in that conversation, because the daughter has 3 little children. But I said, look, you can live with 1 kidney. You're a fit and well young woman. And she went and she went ahead to give a kidney to her mom. And so these are some of the things that it's the belief system, let me put it like that.
Once again, thanks a lot, Dr. Ibi, for making time. We know how super busy you are, and how COVID has stretched you and your colleagues. So we're really, really grateful, for you making time, and we will keep in touch.
No
we
problem.
hope to have you back before the end of the year. But I think the whole issue of, high blood pressure and medication, I think we just need a session on that, and maybe some, pictorial stuff might help.
Yeah. So the next, probably we'll just focus on hypertension and medications, and well, just hypertension and its challenges in treatment. Yeah.
Okay, Doc.
Yeah, just the hypertension and challenges in treatment, so that people will be aware of some of these things. Like a lot of people are struggling with their blood pressures, and there's also this fear that of having all the things that they read on the internet and all the information that are on the internet. Some are good, some are not so good, some are really bad, and the bad ones are more prominent. So people will be aware when they're ready, so that they will be able to see that, oh no, this is a no-go area. There are all sorts of information on the social media now, which are very scary. Okay.
So Doc, the other thing I'll chip in, when we have you back, we would also like you to touch a bit on, traditional stuff, medication, and, some of the things you see. So when we have you back, it will be good to touch on some.
I'll speak on that, because I was in Nigeria. I spoke on about the traditional herbs and its effect on the kidneys. We did a lot of talk there. And I have some photos that we got from them, So one has been doing some work in that area in Port Harcourt.
Yeah, it will be really interesting, because recently one of the fatalities I heard about was someone who was in the UK, didn't want to leave home, during the COVID time, and, ended up having lots of herbal stuff, which sadly, killed the person, So I think that, that's a big thing that,
I'll tell you that I was talking to colleagues in Port Harcourt, there in Nigeria there. I mean, if you look at the cocktail of medicine doctors are giving they are giving them zinc, they're giving them azithromycin, and giving them a cocktail of medicine. But I said, there's no treatment for COVID.
Mm.
And they're giving them that and collecting. Do you know how much in Lagos it costs to do COVID tests? 70,000 naira, 70 grand.
Yeah.
That's what they use. You see, people are making money out of this whole thing in Nigeria there. I've had a lot of information from their colleagues. I said, there's no evidence that there's medication for treatment. They give people zinc, they give them vitamin C, they give them azithromycin, and they give them steroids. I said, you give somebody steroids because they are COVID positive, they are well. You give them all this. It's shocking. So we need to, so that even when we get this information in this forum, we can also educate our relatives and friends.
Yeah.
You know.
Thanks a lot, Dr. Ibi. So once again, everyone, thanks for your time. Just to say that the Health Hour is on every Saturday between 11 and 12. You know, it's the same meeting ID, so make a note of that. On Tuesdays, we have our physical activity and nutrition session. You all heard from Dr. Ibi. Now, it doesn't matter whether you work, you work on the ward, or you have 2-3 cleaning jobs, or you are a nurse or healthcare assistant, you still need to exercise. So come join us on Tuesdays, and then, learn about some of those stuff and take some tips away, as well as the whole nutrition aspect. And, let us all begin to make those reasonable changes. I'm cutting down on the portion of my meal. I know back in Africa, it's when you are rich, that's when you have lots of meats, lots of, a big, massive plate, then it means, yes, you've arrived. Please, let's take away.
Let me just make a comment. In Africa, you should also know that when you're big and when people say they think you're living well, they don't know you're killing yourself.
Yeah. Thanks a lot, Dr. Ibi. And I remember growing up when, you used to have teaspoons of, evaporated milk, and now you can just pick one up. It's 65p in Tesco, and like, oh, I'm going to have loads, like just to make up for the time, growing up in Africa where we couldn't afford enough evaporated milk. So please, just because you can go into KFC and buy loads of food, doesn't mean you can eat, trying to make up for the years when we're all struggling in Africa. So, let's take the advice of our doctors so that we can live longer and help our community. Enjoy the rest of your weekend, and we'll see you on Tuesday. Dr. Ibi, once again, much grateful for your time.
Thank you,
everyone.
Thank you. Bye-bye.
This was live stream, so the video is available. Send it to your friends and loved ones, and those back home, so that we can all learn from that. Bye.
Thank you. Bye.